Hello, my name is Dan Pollier. I'm from the University of Colorado, and this presentation is entitled NCCN Guidelines for Acute Myeloid Leukemia, Where Are We Today? For decades, there were almost no drugs that were approved for acute myeloid leukemia. Looking at the NCCN guidelines, historically, there was always a high priority on participation and enrollment in clinical trials, but realistically, outside of those options, the only conventional treatment options were induction chemotherapy or treatment with low-intensity regimens like hypomethylators. With increased understanding of this disease in the recent years, we've had some newly approved therapies, and that has changed the NCCN's approach to AML, and that's what we're going to review today. The upfront treatment approach via the NCCN guidelines can be summarized to asking a couple different questions about the patient before you. The first question is the patient a candidate for intensive induction chemotherapy? And if the determination, regardless of age or any other factors, is yes, then two pieces of information should be obtained quickly. The first is to ascertain whether the patient has a FLT3 abnormality, and this could be an ITD or a tyrosine kinase domain mutation. If that is found to be positive, a feature of the patient's disease, then midostaurin, the FLT3 inhibitor, should be added on day 8 of induction. And this is based on the RATIFY data published in the New England Journal of Medicine, showing that patients with this disease and treated with midostaurin had a significant survival benefit compared to FLT3 positive patients who were just given 7+3. In particular, if a patient is over 60, another question would be whether they have secondary AML, and if so, then you can consider liposomal cytarabine with daunorubicin, the therapy known as CPX-351, because in a randomized study in this population of patients that received this therapy versus 7+3, there was a survival benefit for the patients that received the liposomal cytarabine and daunorubicin. The second question is, does the patient have core binding factor AML? If they're an induction candidate and they have core binding factor AML, then one should consider the addition of gemtuzumab, the CD33 antibody, on day 1 of induction to CD33 positive patients. The NCCN does not specifically state that you only add gemtuzumab to induction for core binding factor AML, and this may be of benefit for intermediate risk patients as well. This is an institutional decision, really, but what is known is that this should not be incorporated into the treatment algorithm for patients with adverse risk disease biology. If the patient is not an induction chemotherapy candidate, then one should consider lower intensity therapies, such as hypomethylating agents or gemtuzumab if the patient is CD33 positive. The NCCN guidelines comment that if the patient has an IDH1 or IDH2 mutation, you could consider using ivosidenib or enasidenib in the first-line setting, and this would be off-label use. The FDA labeled indication for these therapies is as single agents in the relapse refractory setting. For both fit and unfit patients for intensive induction chemotherapy, a transplant and first complete remission, if appropriate, would be the recommended approach, depending on other factors like disease biology. In the relapse setting, the NCCN guidelines recommends intensive chemotherapy if appropriate for the patient, and there are a number of different regimens that could be considered, all considered fairly equivalent. Hypomethylating agents plus sorafenib in a FLT3 positive patient. Certainly ivosidenib or enasidenib if a patient is IDH1 or IDH2 respectively, following the FDA label as single agents. And gemtuzumab if a patient has a CD33 positive disease. So in conclusion, the NCCN has incorporated these newly approved AML drugs into its guideline algorithms. Gemtuzumab in the upfront setting for intermediate to good risk patients with induction and at relapse should be considered, particularly upfront in the core binding factor population. Midostaurin should be given upfront for all FLT3 positive AML patients who are getting induction chemotherapy. Liposomal cytarabine and daunorubicin for secondary AML patients who are induction candidates should be a consideration and is on label per the FDA. And finally, ivosidenib and enasidenib for relapsed IDH1 and IDH2, respectively, AML patients should also be considered. And per the NCCN guidelines, also consider these therapies in the upfront setting for unfit patients. What do the results of this study mean for those treating patients with acute myeloid leukemia? The NCCN is adapting its guidelines in the light of newly approved AML therapies and continuously changing the guidelines to keep up with data that's available. Thank you very much.